So this is the OAA flexion extension test, and this is the examination for the upper cervical spine or OA region. So the first one we're going to be doing is the flexion, and so you're going to ask the patient to stabilize their chin and ask them to do a nod while they are sitting with their head retracted. And if this reproduces the patient's complaints or a headache, then you have some idea that the upper cervical spine is limited. Now going into extension, you're going to have the patient first in a forward head posture, then lift their chin, and that will really isolate out the lower cervical spine by going into that retraction protraction, and then the additional flexion extension is more for the upper cervical spine. This is the cervical flexion rotation test, and you're going to have the patient here supine, and you're going to flex their head fully, and then you're going to passively do cervical rotation. So you should be able to rotate the patient's head about 45 degrees each way, and then here you're looking for symmetry. So if the motion is asymmetrical by more than about 10 degrees, then that could implicate upper cervical spine as the problem, and that oftentimes what you see when people have cervicogenic headaches. So this test helps isolate for C1, C2 hypomobility and may implicate cervicogenic headache. So this is the TMJ range of motion testing, and we're going to be observing mouth opening. And so when a patient opens their mouth wide, you may either see deflection or deviation. So the first one we're going to be showing is deflection, which is when the mandible deviates from the center and then returns to center at the end of opening. This is also known as the S sign, and this is can possibly show that there is some muscle imbalance or lack of motor control, especially due to the hypertonicity of masticatory muscles. So with the S curve, the muscles are having a little bit of trouble controlling what's going on there, so I would check the mastication muscles to see what's happening. And so now we are going to be showing you what deviation is, this pattern of mouth opening. So this is when the mandible deflects to one side with mouth opening without returning to the center position at the end of the range of the opening. Deviation, or it's also known as the C pattern, which may implicate a capsular pattern or internal derangement. For lateral deviation, when our patient goes into mouth opening, we're going to observe what happens. So in mouth opening, when the patient has a lateral deviation, you have to observe to see if the deviation occurs in the beginning of mouth opening or at the end. So we will show you both ways. So when we ask the patient to open their mouth, and if you see the patient deviate at the beginning, so this example, she's deviating to the left side, that is indicating that they have some hypomobility onto that left side. Now we will show you deviation at the end of mouth opening. So if we have the patient open their mouth, you see the deviation happens here at the end. So for this example, she deviated to her right. So this indicates that she has some hypermobility on the left or the contralateral side. So this is the resisted isometric cervical strength test, and so we're going to be placing the patient into flexion, extension, side bending, and rotation. So we are going to tell our patient to provide resistance against our pressure, and we are looking to see if the patient is able to resist the pressure and see if I can reproduce their symptoms. So now we'll be testing the myotomes, and we're going to be testing myotomes C1 through C8 and then T1. So when we're testing myotomes, we're going to hold for about 10 seconds and see if the muscle fatigues. And if the muscle does fatigue, then you know that there is a nerve root issue. And for the purpose of this video, I'm not holding the complete 10 seconds. So this is the craniocervical flexion test, and this tests the deep cervical flexor muscles. And so you are going to need a pneumatic pressure device, which the patient lies supine with their knees bent and their head in a neutral position. And so you can use towels to keep the head and neck in mid-range neutral. So you'll have the inflatable pressure sensor placed under the cervical spine. So the pressure device is inflated to 20 millimeters of mercury, and while keeping the head into its position, so no pushing down or lifting up, the patient will flex their cervical spine by nodding the head into 5 graded segments of increasing pressure. So from 20 to 22 to 24 to 26 to 28, and then 30 millimeters of mercury, and hold each for 10 seconds, and then with 10 seconds rest between each segment. So we want to make sure that the superficial muscles, like the sternocleidomastoid, must remain relaxed and is not used. And so a positive test is considered if the patient cannot increase the pressure to at least 26 millimeters of mercury and is unable to hold a contraction for 10 seconds or uses the superficial neck muscles or extend the head. So again, it is considered positive if the patient can't hold 10 seconds at 26 millimeters of mercury without substitution. So this is the deep neck flexor endurance test, and you're going to have the patient lying supine, and the chin is going to be maximally retracted by the patient and maintained while the patient lifts their head and neck until the head is about 1 inch off of the table. And then again, so while their chin is maximally retracted, so chin tuck, you're going to ask them to hold that, and you stop the test if there is a loss of the chin tuck or if the head touches your hand. And clinically, it's going to be good if the patient can get to at least 10 seconds and without substitution. So now we are going to be testing the cervical muscle length of the upper traps. And for this muscle length test, we will have the patient into cervical flexion. So you can either use the table, if you can, to hold the patient into flexion, or you can hold the patient into flexion manually, which I'm going to be doing. So you want to passively flex the patient's head, side bend away, and rotate toward the tested side. And you're going to be depressing the scapula with the other hand at the same time. And here you are looking to reproduce the patient's symptoms, and you're comparing the left to the right and see if there is a difference. Now we will be testing the muscle length of the levator scapulae, and again you're going to have the patient supine, and you can either use the table to flex the patient's head or do it manually again. So you're going to flex the cervical spine, rotate, and side bend away, so contralateral from the tested side. And then again, you're going to depress the shoulder with the opposite hand. Then again, you're going to compare one side to the other. So now we will be testing the cervical muscle length of the sternocleidomastoid. And with this, you're going to want the patient supine, but with their head off of the table because you want to slightly extend their neck. And then after that, side bend away and then rotate toward the tested side. And then you're going to use your other hand to increase the stretch by depressing the sternum. So if you're testing the left side, you're going to put the patient into extension, side bend to the right, and rotate to the left. And then if you're testing the right side, you're going to put the patient into extension, side bend to the left, and rotate towards the right. So now we're going to be testing the cervical muscle length of the scalenes. So there is the anterior, middle, and posterior scalene. So you're going to be comparing both sides, the uninvolved, then the involved. So we want to remember, we want the patient to do this themselves. The patient doesn't provide the passive motion because we can easily create a zinger down their arm, so it's better if they can stretch themselves. So again, we're going to look to see if there's a difference between the right and the left, what their willingness to move is, and if you reproduce their complaints. So for the middle scalene, you're going to instruct them to place their arm over their head, and with their other hand, they can hold on to the bottom of the chair and pull down, or slide their arm down their legs so they're getting some pull. And then with the head in the neutral starting position, you're going to have them pull themselves into some side flexion. So again, they will do the same on the other side. For the posterior scalene, it's similar, with one hand on top of their head and the other hand on the chair or sliding the arm down their leg to get a pull. But this time you're going to look down into your armpit and then pull next into lateral flexion again. So the last one is the anterior scalene, and again it is similar to the other two, but instead of running the arm down the leg, you're going to have your arm behind your back. Then you'll rotate your head away from your armpit, so facing the other side, and then you're going to pull your head into some side bending. So for the upper cervical ligamentous testing, you can do the cervical distraction test. You can either do general or AA distraction test. So for the AA distraction test, you're going to get your hand under the occiput and have your fingers on your other hand on C2 to stabilize. So you're going to stabilize the spinous process of C2. Then you get your shoulder against their forehead. So as you're creating the distraction and pull on the occiput with one hand, you're using the shoulder to bring the patient's head into a nod as you perform the distraction. You're looking for a clunk or the 5Ds. So now we will be doing the general distraction test. So with the general distraction, use your body now to pull and create that distraction and pull back. Then remember, once you are done with the distraction, you don't want to just let go, you want to slowly bring their head back. Looking for the 5Ds or a clunk. This is the anterior shear test for the upper cervical spine. So what we're going to do first is we're going to use our fingers and apply that onto the AA joint. So what you want to do is you want to find the posterior arch of C1 to start with, and use the lateral aspect of your pointer fingers. So you're going to palpate and find the occiput, come right off of that, and then you're going to be resting onto the posterior arch of C1. And then all you do is lift the patient's head up, and you're going to be holding for 15 seconds. And then here you're looking for a clunk or reproduction of symptoms, upper cervical ligamentous problems. So double vision, nystagmus, numbness around the mouth, and you can do this test as you work your way down along the articular pillar of C2, and you can work all the way down to T1 to test those areas just doing the shear test. So again, a positive test if there's nystagmus, pupillary changes, nausea, increased dizziness, increased facial or lip paresthesia, or lump sensation, and pain is not a positive sign. So this is the sharp pursor test, and this is specifically looking at the transverse ligament and how it supports and holds the dens. So what you're going to do here is you're going to palpate and find the spinous process of C2, and you're going to hold it between your thumb and index finger. So you're going to find C2, you're going to hold that and stabilize, and then use your other hand to put over the patient's forehead and apply a posterior force. So stabilizing with the right hand on the spinous process of C2 and pushing posterior on the forehead while you're bringing the patient into a little bit of cervical flexion. And then what you're looking for is that you get a clunk and if that actually relocates, or again, if you're reproducing nystagmus, numbness and tingling, or dizziness. So a positive test if you get a clunk or excessive motion. This is the alar ligament lateral flexion stress test. This is specific to the alar ligament, testing for ligamentous instability. So this is a stress test for side bending. So you first want to palpate C2, and then you're going to stabilize there at C2. So for this, you're going to hold still and bring the patient into some side bending until you feel C2 start to move under your fingers. So that excessive failure of C2 to move is considered a positive test. If doing this reproduces patient signs or the 5Ds, then that would also be considered a positive test. But typically what's really positive is C2 stays still because the ligament is not intact. This is the alar ligament rotational stress test, which is similar to the previous test, the lateral flexion stress test. So same would be true for the testing for rotation. So you're going to palpate C2, find and stabilize at the C2, and for this you're going to hold them still and you're going to rotate until you feel the C2 start to move under your fingers. If there's a big difference in the direction you rotate, so more than 20 degrees of rotation without movement of C2 indicates injury to the contralateral alar ligament. So this is the AA transverse shear test. And so what you're going to do is use the lateral aspect of your pointer fingers. So just distal to your MCP joint, you're going to stabilize C2 from the side, so applying the pressure to the transverse process. Then I'm going to use my other hand while you're stabilizing still at C2. You're going to use your other hand to push in a transverse direction on C1. So that's where you're creating a shear. So then you're looking for a clunk, any reproduction of symptoms of nystagmus, double vision, numbness and tingling, dizziness. So a positive test is if you see nystagmus, pupillary changes, dizziness, soft end feel, nausea, facial or lip paresthesia, a lump sensation in the throat, and then again, pain is not a positive finding. This is called the brachial plexus compression test, and just like it's titled, so you're doing some compression near the brachial plexus. So you want to palpate, finding the sternocleidomastoid and also the upper traps, and you want to come and try to give some compression with your fingers just posterior to the clavicle, and here you're compressing in on the brachial plexus. So you're going to hold that, and then you're going to see if you can reproduce the patient's complaints. And a positive sign is if the pain radiates onto the shoulder or upper extremity. This is the distraction test. So especially if the patient has radicular symptoms or complaints, you can do this test to see if you can relieve their symptoms. So you're going to come behind the patient and use the heel of your hands and go right underneath the occiput. Then you're going to have the patient lay back and relax on you. And while they do that, you're going to go ahead and lift their head up and provide the distraction. So this provides distraction through the cervical spine, and you would hold this for about 30 seconds, and you're going to see if this relieves any of the patient's symptoms or complaints. And also, one thing to remember, you have to be careful to let their head back down slowly, and you don't want their head to just drop back into their cervical spine. This is the Sperling compression test, and this is neurological testing, so you can do this on a patient who is complaining of radicular symptoms. So you want to test the uninvolved side first before the involved side, and then you're going to compare the two. So you would side bend the head towards the uninvolved side first, then provide a straight compression down, and then you are going to have the patient side bend to the other side, still keeping the head in neutral position, and then again provide that compression straight down. And here you're looking for the differences and the reproduction of complaints on one side versus the other. And if that wasn't provocative, you can also add a bit of cervical flexion and then repeat the test. And again, it's considered positive if you can reproduce the patient's complaints with the compression. You can also do this with the patient in slight extension and do the same thing again where you're compressing down, but you have to be careful. So this is the Jackson's compression test, and it is similar to the Sperling compression test, except the Jackson is into rotation with compression. And so you're going to have the patient rotate their head as far as they can, and you can basically provide, again, the downward compression while they're in the rotation. So you would compare the uninvolved to the involved, testing the uninvolved first, and compare one side to the other. It would be positive test if the patient had pain radiating into their arm or their patient's comparable sign. This is the shoulder abduction relief test, and this is a pain relieving or symptom relieving test, so the symptoms have to be present in order for you to perform this. So this is not really a test, it's more something that the patient is going to describe to you what makes them feel better or worse. But if you do want to reproduce this test, you would have them bring their arm into abduction and place their hand on their head, and they're going to have everything relaxed. So what will happen oftentimes at C4 and C5 nerve root, this puts that on slack and it feels comfortable. So if the patient places their arm up into this position and it relieves their pain or symptoms, this will tell you it's a positive shoulder abduction relief test. So this is the upper limb neurodynamic test for the median nerve. So when you have upper quarter or numbness and tingling symptoms and you're trying to differentiate between a nerve root problem and a peripheral nerve problem, you can assess neural tension test. So this median nerve test, you want to visualize where the median nerve runs. So you're going to gradually put stress on that nerve. And you want to make sure before you start, you need to depress the scapula and bring your patient starting position in about 90 to 100, 110 degrees of abduction. After the arm is in abduction, you're going to have the patient go into supination, external rotation, wrist extension, and then the last thing that you go for is straightening the elbow. So you always want to test the uninvolved side before the involved side. And then also if the symptoms weren't reproduced, you can further sensitize this by having the patient side bend away. And so a positive test is if you can reproduce the patient's symptoms. Another upper limb tension test is for the radial nerve. And so again, you want to test the uninvolved side before the involved side. So first you want to again stabilize the shoulder, and then before getting them into the position with their arm, you're going to have them cover their thumb with their fingers. Then you're going to bring out the arm into some abduction, and then you're going to pronate and put the patient into wrist flexion. And then again, you're begin to straighten the elbow. And here you're going to look for reproduction of any of the complaints along the radial nerve distribution. So you could further sensitize this test by having the patient side bend away again. And then a positive test is if you can reproduce the patient's symptoms. So the last upper limb tension test is for the ulnar nerve. So again, you're going to depress the scapula, and then you're going to bring the arm into some abduction, but then you're going to come back and bring the hand basically so it's going to touch the patient's ear. And if that, again, does not respond to the patient's symptoms along the ulnar nerve, you can further sensitize the test by having the patient side bend away. Remember to test the uninvolved side first before the involved side, and a positive test is if you can reproduce the patient's symptoms. So a test for upper motor neuron lesion testing is the Laramite sign, and if you suspect a cervical myelopathy with possible upper motor neuron lesion, you could do this test to look for the Laramite sign. So you have the patient in long sitting, and it's kind of like the slump test where you're going to have the patient in a bent down posture, and you're going to have them flex at their head, and then you perform a passive straight leg raise on one of their legs. A positive response would be if the patient had a electric type of pain down into their extremities, whichever extremity the patient is complaining of, and that would be indicative of an upper motor neuron lesion. So again, a positive test, if it reproduces sharp electric type pain, that can indicate a cervical myelopathy and some sort of dural or meningeal irritation. This is the Houghton's test, and this is a vascular clearing test that you can do if you're concerned about any vascular issues as you're treating a patient with cervical spine complaints. And you can do this two different ways. So the first thing you do is have the patient sitting and flex and bring their arms up to shoulder height and their palms facing up the ceiling. So you're going to have them shut their eyes, and while they have their eyes closed, you're going to watch and just make sure that their arms are still. You want the patient to hold this in between 10 to 30 seconds. And if their arms begin to move with their eyes shut, that would be more indicative of a non-vascular problem. Then you're going to have them relax, and then you're going to repeat this test, but this time you're going to go into the exact same position with arms up and also the palms up, but now you want them go to turn their head and look back over their shoulder. So this way they are getting some side bending, extension, and rotation. And then again, you're going to have them shut their eyes, and you're going to watch and make sure that they can hold their hands up. And in this position, if their hands move, then again in that 10 to 30 seconds, now because you've shut down that side, it would be more indicative of a vascular issue. This is the vertebral artery quadrant test, and this is another vascular clearing test that you have to do before mobilizations or manipulations in the cervical spine because you want to assess the vertebral artery. So you want to go into that vertebral quadrant test, which basically involves bringing the patient into some cervical extension, side bending, and then rotation. And then you're going to want the patient to keep their eyes open at all times, and you want to watch them and have them hold and stay there for about 30 seconds, and then you're going to be looking for any nystagmus, any dizziness, any double vision. And if you do see any of these signs, you are not cleared to do any mobs or manipulations, but you are allowed to proceed if you do not see these signs or symptoms. So what some clinicians will do, because it's almost the position you would put the patient in for a manipulation or mobilization, they call this the pre-manip hold. So if you knew that you were going to bring this patient into that position for treatment, you're going to want to do this test first before doing any mobilizations. So again, you would verify that this position does not reproduce any of the nystagmus or dizziness. So this is the first rib mobility testing, and this is part of your cervical assessment if you feel that the first rib has some involvement, and you can assess its mobility by having the patient lying supine. And then you want to go just posterior to the clavicle and palpate until you rest your fingers on either first rib. Then you can have the patient take a deep breath in and out, just palpating and watching for any asymmetry. So does one side move more than the other? And then the next thing you do is while you're still resting your fingers on the first rib, you could have the patient side bend. So side bend to one side, and then you should feel the opposite rib move and lift up under your fingers. And then you're going to do the same by having them side bend to the other side. So here you're just assessing for symmetry and or if the patient has any reproduction of their complaints. So a positive test is asymmetry in motion between the two sides. This is the Adson's vascular test, and it is a thoracic outlet syndrome test. So what you would do here is you're going to take the person's hand and you're going to find their radial pulse, and then you're going to bring them into some external rotation and slight shoulder extension. And then once you get into that position, you're going to have the patient turn their head towards you, so turn towards the ipsilateral side. And then you're going to ask the patient to take a deep breath in and hold. And then while you're palpating for the pulse, if the pulse stops or goes away while the patient is holding their breath while you're having them in that position, that would be considered a positive test. So again, a positive test if diminished or occluded radial pulse in the test position while holding the breath. This is the costoclavicular test, which is another thoracic outlet syndrome test that is similar to the Adson's test, except there's no neck rotation. So with this test, you're going to bring the arm into more extension, external rotation, and slight abduction, again palpating the radial pulse. And once you get back in this position, you're going to see if the pulse is diminished or goes away. So again, you're going to retract and depress the shoulders while protruding the chest in an upright posture, holding about 60 seconds. And then it is a positive test if the radial pulse is diminished or occluded. This is the Roos test, another thoracic outlet syndrome test, and you can do this to assess either for neurologic dysfunction or vascular dysfunction. So what you're going to do is you're going to ask your patient to bring their arms up into what looks like a goalpost position with your arms, and then while they sit there in that position, you're going to have them open and close their hands, and it doesn't have to be too fast or too slow, but you want to perform this opening and closing of the hands for 3 minutes. And it is a positive test if you're unable to complete this, if there's ischemic pain or significant weakness and heaviness. So if the patient has more of a neurologic complaint like numbness and tingling, that would be more indicative of possibly a neurologic component of the thoracic outlet. But if they start to get blanching of their hands or changes in temperatures of their fingers, that's more a vascular type. This is the right test or maneuver, which is another test you could do to assess for possible thoracic outlet syndrome. And for this test, you're going to take the person's arm and you're going to abduct them to about 180 degrees if you can and externally rotate. And then you're going to palpate the radial pulse and see if the pulse is diminished in this position. So you're going to hold this into abduction for about 1 to 2 minutes, and then again assess for diminished pulse and or paresthesia or the patient's symptoms. So this is the shoulder girdle passive elevation test, and it's another test you can do if you're suspecting thoracic outlet syndrome. So this is a symptom relieving test, so the patient needs to have the symptoms for you able to perform this. So you're going to have the patient cross their arms over their chest, and you're going to come behind that patient to support their arms, and you're going to passively shrug their shoulders up. So this is basically putting the thoracic outlet on slack. You would stay here for about 30 seconds, and you would see if this were to relieve any of the patient's symptoms. If the patient's symptoms are relieved by putting that on slack, that would be considered a positive test. So again, you have to hold for 30 seconds. If you have neurologic relief, that means it'll change from numbness to paresthesia. Or if you have vascular relief, you'll have stronger pulse, increased hand temperature, and improved color of tissues. Now we're going to be doing reflexes. So the first is brachioradialis C5, C6. So first we need to find the muscle by having them bring their arm up into flexion at the elbow or an arm curl as they are resisting your pressure. Because when you do this, you should see the muscle pop up, and that will be your point of reference. You also want to make sure you aren't holding their hand under your arm because you want it relaxed and out where it can move, because with this reflex you should be able to see that movement in the hand. You can now use the reflex hammer and give it a light tap. Now we are doing the biceps reflex C6. So first we have to find the biceps tendon. You're going to hold the arm in a similar position and ask them to resist your pressure. Once you find the biceps tendon, you'll place your thumb right over it, because this time you will tap the reflex hammer on top of your thumb. That is over the tendon. Now we're doing the triceps reflex C7, and you're again going to find the triceps tendon first by having them resist your pressure. Then once you locate the tendon, again you'll tap down with a reflex hammer. This is the jaw jerk test, and it is one of the deep tendon or stretch reflexes that can be used to test trigeminal function. So the starting position is having the patient's mouth relaxed and open in the resting position. Then what you're going to do is place a thumb on the patient's mandible, and then you're going to lightly tap the thumb with the pointed end of the reflex hammer. And a normal response is in which the mouth closes, and a lesion superior to the pons would produce hyperreflexia, and a lesion below the pons would result in hyporeflexia. Now I'll be explaining on how to palpate the masseter muscle, since I don't have gloves with me. So the masseter's proximal attachment is the zygomatic arch, and its distal attachment is the external surface of the ramus of the mandible. The masseter's actions include elevation of the mandible and slight protrusion when there's a bilateral contraction, and there's a slight ipsilateral excursion when there's a unilateral contraction. So to palpate this, you're going to use your fingers, so you're going to palpate between the thumb extraorally, and then use your index finger intraorally to palpate the muscle. And then you're going to have them clench down to feel the contraction of the muscle. But an easier way to palpate the masseter is you're going to use the proximal and distal attachments and find that first, and then go to the middle of the muscle belly, and you can have them clench their teeth down, so close their mouth, and this you can feel the contraction under your fingers. Now I'm going to be explaining how to palpate the temporalis muscle, since we have to leave our masks on. Its proximal attachment is the temporal fossa of the cranium, and the distal attachment is the coronoid process and on the anterior edge of the medial surface of the ramus of the mandible. The muscle's actions is elevation, so mouth closing, and also some protrusion because of the posterior fibers when there is a bilateral contraction, and there is also slight ipsilateral excursion when there is a unilateral contraction. You can have the patient open their mouth to palpate the insertion of the temporalis on the coronoid, and then have them clench their teeth and also palpate the muscle in the temporal fossa as well. Now I'll be explaining how to palpate the medial pterygoid since I don't have my gloves with me. So the medial pterygoid's proximal attachment is the medial surface of the lateral pterygoid plate of the sphenoid, as well as the posterior side of the maxilla for the superficial head. And for the distal attachment, they're going to be attaching at the internal surface of the ramus near the angle of the mandible. The muscle's actions when there is a bilateral contraction is elevation, so again mouth closing, and some protrusion. When there's a unilateral contraction, there's going to be contralateral excursion. So when palpating this muscle, you're going to palpate along the inner aspect of the lower teeth, so intraorally. You're going to rest your thumb on the outer angle of the mandible, and the index finger is aiming towards where the thumb is, but intraorally. And to verify you're at the muscle, you're going to ask them to deviate or have them do a contralateral lateral excursion. So since I'm palpating the right side, I would have them deviate to the left. Then you should feel the muscle fire and pop up under your finger. Now I'll be explaining how to palpate the lateral pterygoid. However, there is some controversy regarding the attachment sites because the degree of variability, but there are two distinct heads, the superior and inferior heads. So the proximal attachment is the greater wing of the sphenoid and the lateral pterygoid plate, and the muscle tends to run horizontally, and it has a common, more distal attachment where it's going to attach in the disc capsule and the neck of the mandible. So its attachments more distally are combined on several structures. So with bilateral contraction, the muscle's action is protrusion, which this is a really powerful muscle for protrusion, and with unilateral contraction, it does contralateral excursion. So to palpate this, you want to palpate on the outer aspect of the upper teeth, but still intraorally. So when you do this and your finger is in the right position, you're going to have them go into protrusion, and then you should feel the muscle contract. Now I'll be explaining how to find and maintain the resting position of the tongue. So this is not really an exercise, but something you can teach your patient to do 6 by 6, which is 6 reps 6 times a day, to self-check and see if they're in this position. So what studies show is that when you go into this position, called the resting position of the tongue, the study checked muscle activity of the masseter and pterygoid, and the EMG activity drops when you're in this position, so it's a way to calm this area down. So you're going to explain to the patient that they should have a freeway space, which is where your top and bottom teeth are not touching. So you're going to instruct them to, with their tongue, feel the roof of their mouth, so feel the ridges in their mouth. And you can also describe it as when they're getting ready to say the word no. When you say the word no, you have your tongue up in the roof of your mouth. Or you can also describe it as when they're making a clucking sound with your tongue. So that's also placing the tongue on the roof of their mouth. So while they're in this position, you can have them practice breathing through their nose and trying to swallow. So trying to notice how often they're not in that position, so bringing that level of awareness to them. So you can also have them do this in front of a mirror so they can see themselves, and you don't want any deviation. So if you start to deflect or deviate, you want to make sure to notify them or stop them or have them be aware.